let me introduce one of the very eminent professors in the Egyptian University of Mansoura. Is Professor Mosaad Soliman. He has a long career of publishing a lot of paper, a lot of research, and in charge of the Vascular Unit Mansoura. His talk is about the Egyptian in the light of international guidelines of CAT syndrome. Professor Mosaad.
Thank you, Mr. Chairman. We have been honored by all of the vascular specialists and contribution to the Egyptian guidelines, and I was very privileged to be part of this contribution, especially in the field of VTE and the critical ischemia. And we have had a kind of a long time of conversation, of searching to reach a conclusion and making the final touches of such guidelines. And being through this, I was incorporated in the VTE together with Professor Imad Hussein, to Professor Rashad Bishara, Shafiq Balba, Muhammad Ma'dawi, and we have had such a kind of CAT, and the conclusion turned out to be in favor of the DWACs versus the low molecular way in the initiation and the different stages of therapy of CAT patients. And going through the international guidelines, we have figured that different issues has been raised and highlighted, like in the ACCP in 2021, and also in the ESMO 2023. And they have highlighted the area of endoluminal tumors, like in the GI and the urothelial tumors. At this point, they recommended the use of safe kinds of interventions like apixaban and the low molecular weight heparin rather than edoxaban and rivaroxaban because of the increased risk of bleeding in such patients. And moreover, in the ESMO, they have segregated through 3 groups of patients: those who are at very high risk of bleeding, like with endoluminal tumors, those who are receiving inducers or inhibitors of cytochrome and B-glycoprotein, and those with a risk of bleeding, like patients with a recent attack of threatening bleeding or those with mucositis. These patients, they recommended the use of low molecular weight heparin as a one bunch of patients, and all the other group should receive either low molecular weight or DWACs. And this also runs for patients with extended therapy due to local unresected advanced tumors or those with METs for more than 6 months. And we have some other groups of patients that they need to be looked at, like patients with gastric or gastroesophageal tumors, and these patients again had the recommendation in the NCCN guidelines 2024 to use apixaban or low molecular weight heparin in such patients. The other group are the patients who develop any kind of gastrointestinal resection surgery, because as we all know, DWACs are mainly absorbed through the GI. And if the GI is involved in resection, there are 2 patterns for these patients. Can we give the DWACs through a nasogastric tube? And the answer is yes, we can use a nasogastric tube using a suspension of the DWAC you are going to use in 60 milliliter to be given with meal for the rivaroxaban, 15 and 20 milligram, but not for the 2.5 and 10 milligrams. Worth noting that dabigatran cannot be given through a nasogastric tube. And when you give a nasogastric tube form of the wax, it should be given within 4 hours because it remains stable for 4 hours only. The other part of this is when you have a resection of the GI, it affects the absorption of the wax. Like if you do a partial or total gastrectomy or a proximal GI resection, in such a case, there will be a reduction of absorption of all types of the wax. If you do a row on Y, or in cases of short bowel syndrome or colonic resection, there will be a reduction of absorption of apixaban because its absorption goes further into the distal GI. So this point needed a highlighting in the guidelines. The other thing is the kind of interaction between the chemotherapeutic agents with the DOAC to be used or the anticoagulant to be used. And there are different zones to be taken in consideration, like there is no interaction or no action needed, or monitoring therapy, or considering therapy modification, or avoid such combination at all marked by X, like in the first drug in use. Special cases that needs attention again when you are using DOACs is the kind what we call it CAT. So we have the HIT, which is the heparin-induced thrombocytopenia, and we have the KIT, which is the chemotherapy-induced thrombocytopenia. And what we mean by chemotherapy-induced thrombocytopenia, it is a drop of the platelet count to a crucial level, which is 50,000. So if we have a patient with 50,000 platelet count, and you use any kind of anticoagulation, the risk of bleeding goes into a surfing way. So what you got to do, we have two scenarios in such cases. If you have a proximal DVT in a patient who have received the medication for less than 1 month, then you have two choices. You either continue your anticoagulation while inserting an IVC filter, or you stop the anticoagulation while correcting the platelet count to a normal level above the 50 with platelet concentrates. The other scenario, if you have one of other choices, like patient with distal DVT, or patient with castor-related thrombosis, or patient with upper extremity thrombosis, or the patient who have received already medication for more than 1 month. In such a case, you can go for any of the following. If you have a castor-related thrombosis, just stop the anticoagulation and remove the castor. If you have a distal DVT, you can stop the anticoagulation, monitor the distal DVT. If it proceeds toward a proximal form of DVT, which happens in 10% of the cases, you can reinsert and give the full dose of anticoagulation. The third group of patients, you can do a moderation of the dose. So if you have a platelet count of 50,000 or more, in such a case, you can give full dose of anticoagulation with low molecular weight or the chosen form of DOACs. If you have a 25 to 50,000, in such a case, you should reduce the dose to half the dose of low molecular weight. Below 25,000 of platelets, you cannot invert or use any kind of anticoagulation, whether DOACs or low molecular weight heparin, until you correct the platelet count to the safe level. The other group of patients is those with CAT, in addition to renal impairment. If you have a creatinine clearance between 30 to 60, in such a case, you can choose the low molecular weight heparin or DOACs. If you have it less than 30 of the creatinine clearance, in such a case, you can use either the unfractionated heparin together with VKA, or you use the low molecular weight heparin, but only monitored by anti-active factor 10, which is very expensive as a monitoring method. Last thing is patients who are at extremes of the body weight, those more than 120 kilograms or an BMI more than 40. In such a cases, there is a reduction of the bioavailability of most of the DOACs by 25 to 30%. So in an overweight patient, using DOACs will reduce the efficacy of the DOACs. So it is recommended to use the low molecular weight in such patients. And lastly, I have to comment about the guidelines. It is like the Constitution, when made by the God willing, it needs to be changed. Thank you.